is there any public comment? Yes, the microphone is right there. You'll have 1 minute or 2 minutes to share with us.
Okay, thank you very much, Madam. I've given a handout to all of you, and basically I appreciate what Mr. Allenby and Dr. Warburton have put out there as far as the state improving since they took over. What I have in front of you is I'm Dr. Bussey from the Union of American Physicians and Dentists. And while we realize that I'm the president, and while we realize that psychiatry is the main reason that the Department of State Hospital exists, a relatively forgotten bunch are the doctors, the medical doctors who work there. And so, in a nutshell, I have a memorandum from the medical directors at all of the state hospitals pointing out the stress that they're under and the morale problems they have, working with psychiatric patients who have greater morbidities, physical morbidities. They're working, not to get into, what their demands are, but they have been felt that some sort of a R&R or some sort of a extra salary would be appropriate, as they are truly laboring under both the psychiatric and medical problems that the patients here, 1,000 patient each facility has. And on page 10 you have the vacancy rates on your agenda here, and they're even greater, as you can see from the front sheet. The medical doctors have vacancy rates up to 33% in Coalinga, Vacaville, and Napa. These are about 3 months old, these statistics. I'm not quite sure Dr. Warburton, Mr. Allenby could fill it in. But there's quite a bit of vacancy and a lot of workload that the physical doctors have. And they could go to the CDCR, but they are working in a very dangerous and stressful environment, and they would really consider some sort of R&R to be in order. So that's all I have to say.
Thank you very much.
Is it appropriate to respond?
Sure,
I think Dr. Bussey has pointed out a real problem for our department, and we would very much like to come to you today and say we've got it resolved, but we don't. It is a salary impaction or lack of salary, and collective bargaining is a good thing, but it's not perfect, and this is an area that we really need to work to do a better job in compensating the medical side of the house.
Okay. All right. Thank you very much. One other comment. Yes.
I'm not sure if my name is Margaret Johnson, Disability Rights California. I have a comment on issue 4. Do you want me to wait until you take that up?
Yeah, when we get to issue 4.
Okay.
We'll have a public hearing after the issue. Okay. Is there anything else? Thank you very much. We'll move on to item number 2. Okay. Okay. Okay, you want to begin with item number 2, expansion to address incompetent to stand trial wait list.
Okay, thank you. Mark Beckley, Deputy Director for Administration, Department of State Hospitals. We are requesting $27.8 million general fund to increase our bed capacity in our state hospital system by 105 beds. What this proposal would do is it would allow us to reduce the wait list for incompetent to stand trial patients. Currently, we have a wait list of over 300 patients waiting for admission to our hospitals, and this proposal would help us to admit those patients and admit them in a timely manner. We also have plans in place to increase admissions at our Atascadero State Hospital by 55 patients. So we think a combination of those two factors should significantly reduce the wait list of patients waiting for admission to our facilities. We're also in the process of expanding our Restoration of Competency program. That's a program where we treat patients within jail facilities. That program is currently in place in San Bernardino and Riverside counties. We're seeking to expand those to Los Angeles and Alameda counties. and we hope to do that fairly soon. That could reduce our pending admissions by another 50 patients. So we think that a combination of these factors, the additional beds that we're requesting through this proposal, the increase in admissions through Tuscadero State Hospital, and expansion of the ROC program should allow us to better manage our IST wait list.
Okay.
Sure.
Just a small addition. On the ROC program, we have significantly better outcomes in that the length of stay to become competent is substantially reduced. And one of the reasons that occurs is that not all of the folks that are judged to be incompetent to stand trial are handled within the ROC program, within the regional program. Those are clients that we believe are more likely to be brought back to competency and to require less intervention on our part. For those that are more difficult, even with the ROC program, they will be handled within our hospital system because it requires a lot more interaction and a lot more clinical care than we can provide within the ROC programs. But the ROC program that is in place, and the legislative analyst did a review of it, basically shows that the length of stay for competency in those programs is significantly less than the length of stay within our hospital system. And we think it's a cost-effective and better program. And it's cost-effective to the counties because whether they're provided care in the county or provided care in our hospital system, the cost is borne by the state.
Okay. Any comments from our finance department? LAO? Anyone?
Sarah Larson with the Legislative Analyst's Office. So the administration provided a good description of this proposal, so I'll just move straight to our recommendations. And since our concerns for both this issue and for issue 3 are similar, I'll kind of cover them both at the same time. So our office is recommending that the legislature reject this proposal and request more information from the department about its ongoing needs. And this is for 2 main reasons. First, we're unclear whether the current budget is an appropriate size or whether savings could offset the requested increases. And second, the high staff vacancy rate means that even if additional funding is provided, it's possible that newly budgeted beds might remain unfilled. So our office is also recommending that DSH contract for an analytically based assessment of their distribution of beds and staffing, and I'll discuss that in just a moment. We do acknowledge that there's been growth in the patient wait list, particularly for the incompetent to stand trial patients, but our concern with this proposal is that it may not be based on an accurate assessment of the department's ongoing needs. So while there's been an increase in certain types of referrals, the department is currently budgeted for more than 500 beds that aren't currently being used. We do recognize that some of those beds are reserved for certain purposes. For example, the department has noted in discussions with us that some beds are for medical purposes or reserved for patients who are out to court. However, we're concerned that the department appears to be consistently over budgeted in this fashion, and because annual per patient costs are very high in the hundreds of thousands of dollars, an additional 500 vacant beds represents a substantial amount of savings. In addition, that number of vacant beds does fluctuate, so that does seem to indicate that perhaps the department could be operating with a different volume of vacant beds than it currently has. We're also concerned that the department doesn't have an analytically based bed and staffing model. So, for example, staffing models in the correctional systems include factors like ratios of patients to providers, but also, the volume and appropriateness of the number of vacant beds, how those beds should be staffed, the appropriate distribution of bed types, those sorts of elements. And without that sort of information and kind of formula-driven ratio, it's difficult for the legislature to determine whether the requested augmentations are appropriate. Our second concern is that this particular IST proposal is based on the assumption that the department can staff the positions associated with the IST beds. But as noted in the agenda, there are very high vacancy rates at the state hospitals and psychiatric programs. So approving this augmentation could possibly not result in staffing increases because hiring is a challenge. And the additional beds proposed may remain vacant because of that. So in summary, we recommend that the legislature reject the current proposal to provide additional capacity for both the IST and the Coleman patients. And we would recommend that they direct DSH to report at May budget hearings on the number of vacant beds at that time, how savings related to those vacancies might be diverted to fund this staffing request or this bed request, as well as reporting on what steps are being taken to address the high vacancy rate. And we also recommend the legislature direct the department to report in May on what progress has been made to expand the patient management programs, for example, the Restoration of Competence program that the department mentioned, because expansion of that program could possibly result in a reduced need for more beds. Finally, we would recommend that the legislature direct DSH to develop a proposal to contract for an independent analysis to determine appropriate numbers of vacant beds, appropriate staffing levels, and other related factors for each facility. So that's all of our recommendations on these proposals, and I know it went kind of fast, so if you guys have any questions on those, I'd be happy to answer them.
Okay. Any other finance report?
If I
Okay.
Mark Beckley, Deputy Director of Administration for Department of State Hospitals. Just to provide some responses, and we did meet with the LAO, and we really appreciate working with them on these bed capacity issues. Currently, the Department of State Hospitals has a 4% bed vacancy rate. That's approximately 221 beds. The majority of those beds, 3/4, are reserved for specialty services such as geriatric patients, medically needy patients, deaf, visually impaired patients, as well as admissions units. So you need to keep a flow of patients. We also have beds that are reserved for specialty populations, and you really would not want to mix other populations in with these, such as your sexually violent predators. And the Coleman Court beds are ordered by the court, so we don't have an option to use those for other purposes. Overall, in terms of savings, we expend 98 to 99% of our budget. So we're really slim in terms of year-end savings, so we don't think that there's much there that would be available for redirection. And in terms of staffing, where we plan on housing these beds in Coalinga, we have not had difficulties hiring staff there, at least contract staff. So we've just opened up a new unit there. It's fully staffed, accepting patients, and that's where these units are proposed to be housed. So we do feel that if this funding is approved, we would be able to fill these beds. And it would have a positive impact on reducing our wait list.
Okay. Any questions from staff, from anyone else? Questions from legislators? Do we have any public hearings?
Good afternoon, Madam Chair and members. Corey Salzillo on behalf of the California State Sheriff's Association. We support the requested budget item for not only for the incompetent to stand trial for the new beds, but we are also supportive of the concept of expanding the pilot program as it currently exists in San Bernardino and Riverside County. It's a very successful program. It does a very good job of restoring competency, and I would just let the committee know, as you may be aware, this is an item that affects many different parts of many different systems. It's not just a state hospitals issue. Persons who are incompetent to stand trial, for the most part, sit in county jails waiting for a ride to the state hospital. They take up jail beds, they decompensate, and the problem gets worse once they get to the state hospital. If they're able to be restored, they come back. If we can't do that quickly and successfully, they run the risk of decompensating. So we're just here to support this request, and we think it really helps multiple systems on multiple levels. Thank you.
Thank you. Anyone else? Any other comments? Any comments, any from us? So I gather the need for beds, additional beds, despite the vacancies that are there, is because you've decided to have certain specialty beds or certain needs that demand a different kind of, no. Okay.
Part of it's a licensing problem. I mean,
Okay.
we don't have the capacity to interchange certain beds because of licensing issues.
Okay.
And we don't want to have a mix when we shouldn't have a mix. And so we do have vacant beds at times. But the proposal basically is to add beds at Coalinga and then to take beds at Napa and Patton and move them, Metro, and move them to Coalinga so that we can free up beds in those hospitals that do have incompetent stand trial programs. So we think it's a well thought out program and does make sense. and will reduce the wait list significantly.
Okay, fine. We need to call roll to establish a quorum. Okay.
Weber.
Here.
Chesbro. Dickinson. Grove. Mansour.
Okay. This is an action item. Is there a motion for this action item? It's been moved and second for the staff recommendation. Please call the roll.
Weber.
Aye.
Chesbro. Dickinson. Grove. Mansour.
Okay, 3 votes, it's out. Approved. Okay, thank you. We're now to item 3. Okay. Which had some relationship to the other one, but okay.
Okay. Mark Beckley. The first question asks to provide an update on staffing and bed migration to the Stockton facility. The migration of patients from our Vacaville and Salinas Valley facilities, as well as direct referrals off of the Coleman wait list, is going very smoothly. We have had difficulties in hiring psychiatrists for the Stockton facility, which has delayed our implementation of Stockton. We had originally planned to have the facility fully implemented by December 2013, but due to our psychiatrist hiring difficulties, we've delayed that, the full activation. We're pleased to report that just over the past 2 weeks, we've hired 4 additional psychiatrists for Stockton. This enabled us to open up 2 additional units today, and in April we'll be opening up another unit. So that will have us have activated 15 of the 17 units, and then that'll just leave us with 2 more units that we still have to fill. We currently have 791 out of our 914 positions filled, so that's an 86% fill rate at Stockton. And we're currently serving 308 patients. And once these other 2 units are up and running, we'll have additional patients at that facility.
Okay. Any comments from the finance or LAO? I think you probably covered it last time, but that's okay if you want.
Sarah Larson with the Legislative Analyst's Office. Thank you, Madam Chair. Just a couple of clarifying points on our comments earlier. We wouldn't propose transferring any bed space for these proposals. We would propose transferring funding or looking into the transfer of funding. So just wanted to clarify that point.
Okay. Any other comments from finance, LAO? Okay. Any questions from the legislators here? This is an item we'll hold over.
Yeah, I think it's appropriate to hold open because we're still working with CDCR to determine how many we're going to be getting so that we'll have better information in May.
It's a recommendation to hold it until over. Any public comments on this matter? Okay, if not, then we'll move on to item number 4, statewide enhanced treatment units to capital outlay. Okay, staff.
Mark Beckley, Department of State Hospitals. The first question asks, poses the question of how DGS can develop an analysis of our cost estimate construction plans absent more specificity. We actually have been working with CAPT and with other unions on a bill that's currently in progress, AB 1340, providing technical assistance to that. And we think that our ATU proposal would be very similar to what AB 1340 proposes. So that does contain quite a bit of information on how ETUs would work, the need for the ETUs. We are also developing further guidelines that would describe the function and referral process of the ETUs, as well as due process considerations that we'd build into to referring patients to these ETUs. Once those guidelines are developed, we'd be happy to share that out with your staff, and we can have further discussions about the guidelines, the referral process. So this is definitely a proposal that is still evolving and under discussion. We've also had discussions with DRC on this proposal as well.
Okay. Any comments from finance or LAO? Either one?
Carlos Ochoa, Department of Finance. I did want to point out that we are working on a study, and we're anticipating a May revise item to provide further analysis and cost estimates for the proposal.
Okay, thank you.
Thank you, Madam Chair. Sarah Larson-Elio. So we would recommend that the legislature reject the current proposal. Under current licensure by the Department of Public Health, DSH doesn't have the authority to operate units with locked doors, and the proposal doesn't include any language that would provide the department with that authority. And since AB 1340 is still working through the policy process, there's still no clarity on what would happen there. Unlike the proposal that we'll hear later on the patient management unit, which would have relatively straightforward statutory changes, this has a more complicated policy consideration. For example, there's no clarity about whether these locked units would be at all hospitals or only certain hospitals, whether they would require bathroom facilities, so plumbing, what size rooms would be provided, et cetera. And without those details, it seems to us that it would be difficult for the Department of General Services to provide the analysis that's suggested in the proposal. So while we recognize the need for enhanced treatment space in DSH facilities, we believe this proposal is premature. So that's our recommendations, and I'm happy to take any questions.
Okay, this is an item we've also recommended to hold over for additional information. Any questions up here? Mr. Dickinson, did you have any questions? Okay, do we have any public comments? I think your item number 4, yes. Okay, we'll give you 2 minutes.
I'm such a shorty. Thank you. Margaret Johnson again with Disability Rights California. Just wanted to let folks know that we definitely agree with the development of enhanced treatment programs. The ones at Coalinga and Atascadero State Hospital are very impressive. I had a chance to go look at those. However, the current budget proposal are premature and troubling for a number of reasons, and I'm just going to mention a couple today. First, we're troubled by the desire to ask for funding to create rooms to lock patients into. The existing programs at Ash and Coalinga are already unlocked units of about 12 to 20 patients, and Department of State Hospital can currently expand those programs without doing any changes to the law. The request for funding of locked rooms makes no sense because, as the LAO pointed out, seclusion restraint laws must be followed, and to do otherwise takes away personal liberty without due process. Second, we're troubled by the lack of due process. Due process requires a review by an impartial decision maker during which the patient is represented by an attorney or advocate and can put on evidence and cross-examine witnesses. The Department of State Hospital's current process, as we understand it, is flawed in that it is an in-house medical review only. We urge you to reject this budget request as premature and not necessary. Thank you.
Thank you.
Madam Chair, members, Kobe Pizzati with Merch Bassoff and Associates. We represent the California Association of Psychiatric Technicians. We and the 5 other labor organizations that work at all the state hospitals came together in 2010 after the murder of psychiatric technician Donna Gross to form the Safety Now Coalition. Through that coalition, we have been able to implement many changes to hospital safety. Some of them, such as ground presence teams, greater hospital police numbers inside the facilities, as well as personal duress alarms. But the number one priority for our unions is this program right here, the Enhanced Treatment Program. I've heard from the department that roughly 3% of the patients cause roughly 40% of the violence. We need to be able to provide safe and effective treatment in an environment in which our members can be free of fear and that other patients can be free of fear. We are the sponsors of AB 1340. Well, we, the Safety Now Coalition, are the sponsors of AB 1340. And in the in the interim, we had 3 stakeholder meetings, including Disability Rights California, and we included them because we wanted their input and their voice into crafting the legislation. And they had a large portion of the final version, which is now being amended in Senate Health right now. So with that, I have to say that this is the number one priority for us. The licensing and the due process procedures will be in AB 1340, and they will be in print hopefully sometime next week. So
thank you.
We support this.
If I may, Madam Chair, I'd like to ask our medical director to give some clinical reasons.
We have one additional
I'm sorry.
comment. One more.
Selena Pryor-Dansby with SEIU Local 1000. I would like to echo the comments of Mr. Pizzotti and also ask you to please consider our concerns for my members who are actually treating these patients that are the most violent and the most aggressive. Thank you.
Thank you.
Thank you, Madam Chair. My name is Mark Victoria. I'm with AFSCME Local 2620. We are one of the locals that are part of the Safe Now Coalition, and again would like to echo Mr. Pizzotti's words. Please support this bill.
Thank you. Okay, you wanted to respond quickly?
I just give our medical director a short time to kind of discuss the clinical reasons why we think this is an appropriate way to go.
I'll try to be brief. Essentially, we're a forensic mental health system operating in an environment and under the rules of civil commitments. It isn't about locked doors, it's about safe treatment. We have data to suggest that a quarter or a little over a quarter of the violence committed in our hospital is predatory organized in nature, meaning there's no pill or behavioral intervention that we can effectively utilize to protect people, nor can we predict when. We can predict if, but not necessarily when that aggression will happen. Related to due process, mental health law does not always require a hearing to satisfy due process. Many courts, including the Supreme Court, have upheld the medical decision-making model for mental health patients, especially when dangerousness is involved. And oftentimes they cite case Matthews v. Eldridge, which looks to balance patients' rights with institutional security. We did build some due process and medical decision-making model due process into this to protect the rights of our patients because we care about our patients. This is about our patients. We're trying to protect our patients. We always operate on the principle of least restrictive environment. Just related to the DRC issues and the natural tension that's going to exist here, when I was studying mental health law as a forensic fellow, there was always a debate about autonomy versus paternalism, and autonomy being valued in a very patient rights oriented system engendered a phrase where someone said they're dying with their rights on, meaning they have their civil rights, but we lose a few people here or there. The problem now is other people are dying. Other people are getting injured, and we need to protect our patients and our staff.
Okay. Thank you.